Thank you very much. So I'm here to talk about increase in size of the hiatus after lung transplant and how that relates to GERD. I'm from Sydney, Australia, St Vincent's Hospital. There we go. No disclosures. Our hospital. So a bit of background. GERD is important in lung transplant patients because it causes aspiration and they get chronic rejection of their transplant. It's thought to occur due to vagal nerve injury and cause dysmotility. So you get ineffective esophageal motility, you get a decreased tone of the LES, and you get delayed gastric emptying. That's the vagus nerve running behind the hilum, and you can see why it gets injured at the surgery. It's directly posterior. Nissen fundoplication is the gold standard for these patients, but we believe that it works not because you've got a vagal nerve injury, but because you're fixing an anatomical defect which is related to hiatal widening. And you notice that hiatal widening is the first step in the pathogenesis of a hernia. Hiatal widening as a concept for reflux is not new. It's been studied in the last decade, and particularly in endoscopic studies, they've noted that when you do the retroflex view on the cardia, the circumference of the cardia directly predicts how severe the reflux is. So this is our study. It's retrospective, case control study, and we got ethics approval, and we looked at 6 years worth of data. Cases were confirmed pH studies that were positive. Controls were were negative on their pH studies, and we excluded anyone that had reflux before their surgery. And we also excluded anyone without CLAD or anyone that's chronic rejection, anyone with a different cause for chronic rejection, and also anyone that had previous thoracic surgery. Our primary outcome measures were hiatal surface area, and we compared that pre-op and post-op on their CT scans. So we had 273 bilateral lung transplants. We excluded most of those due to the criteria that I've mentioned. 15 were excluded for incomplete imaging, and that left 21 cases for analysis. We randomly picked 21 controls to compare that from the initial series. This is how we reconstruct the hiatus. So we take the sagittal and coronal views, and we draw an oblique line right through the hiatus to come up with this double oblique axial view, and then we magnify that up and we do a freehand tracing of the hiatus. That's more of a diagram to get an idea of what we're looking at. It looks very similar to what you see at laparoscopic surgery. This is a patient from the study. He's in the reflux group. He had a normal looking hiatus before the transplant, and then you can see after the transplant, the hiatus is quite enlarged. So all statistics were done with SPSS. Most patients had their transplants due to COPD or interstitial lung disease. You can see there's a balance between males and females. These are our main findings. These are our baseline patient characteristics, and I just wanted to point out that they're similar for both groups. So age, BMI, length of operation, length of stay, and also the FEV1 post-transplant were all the same. And this is just to show that the two groups were different in regards to their reflux. So our results. So both groups had a very similar hiatal surface area before the transplant. But the reflux group, their hiatal surface area increased to 7.04 centimetres squared, which is double what it was initially. Whereas the control group, their hiatal surface area didn't really increase very much at all. Our secondary outcome measures, there was a proportion of patients that was significant that had a weak LES pressure and also a shorter intra-abdominal LES. So these are the box and whisker plots. In the top right, you've got our pre-op hiatal surface area, and then next to that is the post-op hiatal surface area, and then the percentage increase. I'll draw your attention to the bottom left one, and that's the timing of the CT scan after their transplant operation. So you can see that most patients had their CT scan 2 years after their operation. So that's when we were measuring the hiatal surface area. And I just want to point out, if that's the doubling in 2 years, then who knows after that how large it can go. So an important graph also, an important finding was when we looked at both groups in conjunction, their hiatal surface area was directly correlated to the total acid exposure. So that was another additive to the argument that hiatal surface area is implicated in reflux in these transplant patients. So we think that GERD in this group is multifactorial. It's due to vagal nerve injury and also hiatal widening. With hiatal widening, the other factor is the Pinchcock mechanism of the crural diaphragm is affected, so they can't compensate for a sudden increase in their intra-abdominal pressure, such as what happens in coughing and sneezing, and that happens a lot to the transplant patients. So the limitations of this study, it's retrospective, had a small sample size, and we did have some data that's missing from the manometry perspective, but we were still able to come up with significant result. Our conclusions, this is an important new concept in understanding the pathophysiology of reflux in this group. And the whole point is we want to reduce chronic rejection. So we're hoping that a larger prospective trial will be able to determine which patients are at risk of hiatal widening, and we'll be able to pick them out. Thank you.